Okay, welcome everyone. We have one of our virtual lecture series again, and today will be about a new initiative that was initiated by the Dean a few months ago when it became clear that COVID was one of the largest healthcare, well, I think I should call it disasters that, you know, came across this city and the country, but certainly the epicenter was New York. We can fortunately say was New York now, and the Mount Sinai system was, as we say, the epicenter of the epicenter. And as we know from experience from 9/11 and other large disasters, this is invariably going to be followed by psychiatric sequelae such as depression and PTSD. And the Dean found it, rightly so, very important that we provide help for our own people, for the people who have been manning the trenches and have been working so hard to save so many people from this virus. And we know that this is going to happen now. So fortunately, through philanthropy, the possibility had been created to fund a program, and that's the program that's going to be presented today, and that's being directed by the three people that you've seen on your flyer, which is Deborah Marin, who is the director of the entire program. She is on the faculty. She's been on the faculty for quite a while. She is a psychiatrist, and she has also worked in research for quite a while, especially in the field of Alzheimer's disease and other mental health aspects, and is now heading the wellness program as well. She is heading this program. Jonathan DiPiero, who's a psychiatrist as well, has been working extensively in the PTSD program of the World Trade Center, obviously another disaster that befell New York in 2001, and has a lot of experience in working with trauma-related patients. And then Greg Katz, who actually was one of the founders of the healthcare program in the WTC, and he is helping out to build up this program that we're currently going to be discussing, taking care of our own, and he's been instrumental in getting this program together because he is one of the world experts in the field how to cope with disasters, and as you may remember, he has presented that at Grand Rounds for us, which was very highly attended. So with that, I'd like to give the floor, the virtual floor, to Deb Marin to present this unique program, We Take Care of Our Own, which I think will be a trailblazer in the country and of the world. And I hope you're going to enjoy it. Thank you very much for joining, and Deb, the floor is yours.
Hi, everybody. I'm Deb Marin. Renee, thank you very much for that wonderful introduction. So we do have different people presenting today, and the reason I thought it was important is that this was a real team effort to get the center going. There was nothing there at the beginning of May, and we officially opened our doors on Monday, and it's been remarkably helpful that all of the folks who we're talking today have been part of it, and particularly other departments I want to thank too. So I just want you to look at the picture on the right side of the slide and just think about where is this, what is this, and we'll get back to it. So I happened to have been in the hospital during the course of the week when this was going on, rounding and seeing what was happening. And the first thing that happened was a tremendous change in conversion of existing service lines or units into COVID units. The first unit that was changed was a cardiac care unit, a unit that was specifically really for people who had very good outcomes, actually. You know, we have a very large cardiovascular institute, and the people who work there had to be retrained to basically have a medical intensive care unit. And that's true around the hospital. We basically became COVID hospitals, as you know. A big problem is the uncertainty of the illness course. When we started seeing these patients with it, you know, it's a very mercurial condition, as you all know, and very little was known about it. And, you know, physicians and nurses and other healthcare workers rely somewhat on the certainty of illness course, and they weren't able to have that opportunity to do so. In addition, there was uncertainty of illness management. There were certain protocols that kept on changing based upon what is best practice. Even the idea of proning somebody was something that wasn't known for a few weeks. The high mortality rates, in fact, Mount Sinai Health System did quite well. The mortality rates are much lower than other countries having the illness. The challenge here was that there were young, healthy people who come in and they die, and people didn't understand why. And at this time of excess illness and close near-death experiences, for you to know mortality at Mount Sinai Hospital alone would be quadruple a typical day of what it was pre-COVID. In fact, in Mount Sinai Brooklyn, they approached their annual death rate after just about in the first quarter of this year. And then there was visitation that stopped. So then the nurses and other healthcare workers had to become the conduits between the patient and their loved ones, which was very, very difficult. And for the workers, they were often reassigned, meaning a social worker on one floor may go to another floor, or they may have to go to another hospital. Some people were redeployed. For example, physician assistants who worked in surgical subspecialties were redeployed to work in medical subspecialties. So the disruption to the camaraderie in the team or even the location where you work was quite substantial and quite difficult for folks. So this is the Atrium West Lobby. These are units that were built over a period of just a few days in preparation for an influx of so many patients that they could not be taken care of on the floors. Fortunately, they were not used. And this is what a floor looked like. Patients were in rooms, always with the doors closed. And in order to avoid too much contact with the patients, all of the medical equipment was outside. So the typical touch and feel nurses would have or doctors would have wasn't there. And this is what KCC looked like. Holes are made so that the negative pressure rooms could be made. This is a completely different, imagine one day you walk by and you see all these holes there. This is the atrium main area. So what also was disrupted were the ability for employees to navigate the way they normally would navigate to get from point A to point B. What you don't see here is that what it looks here was this coffee area. This was actually converted into a nursing station, which again, I said was not used. This is the inside of Samaritan's Purse tent. They had 36 beds. They were completely independent of Mount Sinai. However, we needed this space very badly, so when patients got well enough and not want to go home, they would be transported here. So recognizing the need for staff care, Renee already mentioned, we're all psychiatrists, psychologists, with clinicians in the sphere. We had a pretty good idea something had to happen quickly. So basically in mid-March, a multidisciplinary task force started. It was John Rip, who runs the Office of Wellbeing and Resilience, and Dan Hughes, who runs the Employee Assistance Program, started a task force, of which I was on, to try to determine what we needed to do quickly to take care of the healthcare workers. There was a lot of expression of a concern from the healthcare workers, actually, to other people. So there was the creation of a system that basically was multi-tiered to provide psychological support. And I do want to mention Craig Cathwell is very important in this too. So because people were so afraid of infecting their family and loved ones, temporary housing and meals were a supply for folks. And Sabina Lim, I have to thank her, rapidly pulled together with John Rip over 60 mental health liaisons to provide in-person and remote support with psychological first aid framework. The concept here was rather than wait for people to call a line to get help, there were 2 or 3 mental health liaisons assigned to either different floors or different hospitals, and they would push themselves and let people know on the units that they were there to help, just to listen, and if necessary, to refer. One of the more creative responses to the program were these recharge rooms. Dr. David Petrino, who works in the Department of Rehabilitation and Performance Enhancement, was able to get funding from the Coleman family, actually, to create these multi-sensory rooms. I'll show you in a minute. And of course, there's a 27 staff support line. The medical students were very, very helpful as well with this. These are the recharge rooms. So these rooms were built on site in different places. For example, one was a waiting room on the cardiac care unit. You would go in and there'd be music, there could be aroma, you could change what you saw. There are over 10,000 visits to these rooms. There were 9 of them in 5 of our hospitals. And about 500 folks gave opinions of how they felt. Before they got in and after they left, they filled out a 6-point Likert scale of whether or not I feel stressed or not. And 60% of the folks who experienced just 15 minutes of this felt less stressed. Nonetheless, we all know what is happening and what's going to happen. I'm going to turn it over now to Jordan Feingold, an amazing fourth-year medical student who I actually had the pleasure of mentoring last year for some of the work she's done. And I'm going to just turn it over to you, Jordan.
Thank you so much, Deb, and to the team for inviting me to speak today. I'm going to go relatively quickly through some of the data that we found in a research study that is ongoing to determine the psychological impact of the pandemic on frontline healthcare workers. So pardon my speed as I go through this. So we sought to understand the psychological consequences experienced by healthcare workers on the front lines at the Mount Sinai Hospital, rather than so only at the Mount Sinai Hospital, not all of our affiliate sites. But we looked specifically at the personal COVID-19 related factors and occupational factors associated with mental health outcomes. So very quickly, this study was administered over 4 weeks during the pandemic surge, which at our hospital was April 7th, and our study period followed this. We had 2,579 frontline healthcare workers from various professions, so it was an interdisciplinary study. And we looked at symptoms of COVID-19 related post-traumatic stress disorder, depression, and generalized anxiety disorder, and used multivariable logistic regression and relative importance analyses to identify the factors that were most highly associated with these outcomes. And the way we operationalize our outcomes of interest were by using validated scales with the cutoffs that you see here. So for COVID-19 related PTSD, we used the 4-item PCL-4-5 with a cutoff score of 8. For major depressive disorder symptoms, we used the PHQ-8. And for GAD, we used the GAD-7. And importantly, we were only looking at symptoms rather than diagnoses of PTSD and GAD. As you know, PTSD requires symptoms for a month and GAD for 6 months, and we only asked about symptoms over the course of 2 weeks. So we're really looking at symptoms rather than diagnoses. Additionally, we ascertained personal factors, importantly, things like pre-pandemic burnout, which we found to be COVID-19 exposure factors at work, things like adequate PPE, number of colleagues who have been hospitalized, number of close personal loved ones who have been hospitalized, the idea of having difficult decisions, prioritizing patients, work-life balance challenges, and then we ascertained potentially protective factors, things like feeling valued and supported at work from hospital leadership, pride, meaning, and inspiration. So our results were as follows. We ended up getting a response rate of 55.8% of those who we contacted via email. And then we were able to analyze a portion of that sample based on those who further endorsed frontline responsibilities and provided sufficient information regarding our outcomes. So we found that 39% of that population that we analyzed screened positive for at least one of our outcomes. And you can see the breakdown of those who screened positive for 1 outcome, 2 outcome, or 3 outcomes, meaning major depressive disorder, generalized anxiety, and COVID-19 related PTSD. And here's the breakdown of those who screened positive. So 26.6% for major depressive disorder symptoms, 25.5% for generalized anxiety, and 23.3% with PTSD symptoms. In our multivariate analysis, we found that pre-pandemic burnout was associated with a higher risk of developing symptoms of all 3 disorders and explained the majority of the variance in these outcomes. Endorsing work-life balance challenges was also associated with a higher risk. And we found that higher perceived support from hospital leadership was associated with a lower risk of all of our outcomes. And other forms of support, such as being married, endorsing camaraderie, were also protective. To get to some of the details, the lack of adequate PPE was associated with PTSD and anxiety symptoms, but not depressive symptoms. The total composite of personal exposures was predictive of PTSD symptoms, probably mediated by proximity to illness. death of a colleague was correlated with major depressive, but not the other symptoms, which indicates some sort of grief reaction might be happening. And colleagues hospitalized or in the ICU predicted generalized anxiety disorder symptoms. So these exposures give us a sense of some of the differences between the symptoms of these disorders and recapitulate some of these nuances of symptoms for each of these scales. And we also found that non-physicians were more likely to screen positive for at least one of the three outcomes. So that was social workers, nurses, physician assistants, chaplains, et cetera. And it might be a real risk based on the nature of the work versus a phenomenon driven by gender. We found that over 85% of those other groups were women, whereas only 59% of the physicians were women. So it might be, as we've seen in the literature, more of an internalizing pathology that can be attributed to gender versus a real risk, or perhaps that physicians actually underreport their symptoms due to fears. So next steps, we have identified opportunities to intervene, and we are continuing to track this cohort of frontline healthcare workers over the course of the pandemic. And really our goal is to prevent new symptoms from turning into new cases of mental illness. And we are also thinking about expanding our population that we're studying to others that we did not capture in this first survey. So I just want to thank the study team and those of you who invited me to speak today. I think I stuck within my 5 minutes, and I will give it over to Jonathan.
Hello, everyone. Thank you for making the time to attend our talk today. I have the pleasure of discussing our center and talking about its aims and scope. So the Center for Stress, Resilience, and Personal Growth is a hub for enhancing resilience and mental health following the COVID-19 pandemic. And we are engaging in evidence-based strategies to enhance resilience, and we also have a significant research arm. So we have a service that is offered at no cost to employees, resilience enhancing workshops, which I'll discuss in a moment, and Craig will talk about in more detail, and a significant research arm. Okay. So let me tell you a little bit about resilience. What do we mean when we say resilience? So resilience has many different definitions. And one definition that we have come to like is resilience being defined as the ability to bounce back after adversity. And in fact, there are many resilience promoting factors that have been identified, including from Dean Charney's work, including optimism, reframing stressful thoughts, living by your values and moral compass, finding resilient role models, facing fears, being cognitively fit and physically fit, and cultivating spirituality in your life. And these factors are modifiable in that we can train individuals to be resilient by teaching them how to cultivate these factors in their life. In fact, that's what we hope to accomplish in our resilience workshops. Okay, let me talk about the flip side a little bit and the stress picture, and Jordan introduced this to us very nicely. So it's clear that our healthcare workers have been exposed to life threat and many secondary stressors, including childcare stressors, financial burden, elder care, fear of infecting their family members. And the symptom picture in samples other than ours is a bit mixed. One study that's been published already from Singapore and India found rates of 7.4% of PTSD in their healthcare workers, but actually that goes up 7 times if you looked at a sample in Italy. So there's quite a range of symptom presentations that have been surveyed. This is all by self-report. And we think that here exposure matters. The intensity, the dose of exposure really does matter. Italy was second to the United States in terms of death toll. And the United States actually has the highest death toll. I checked 3 days ago when I made this slide, it was 112,000 deaths. So we would expect our healthcare workers in the United States, and in particular New York, as Jordan showed, to be highly impacted in terms of their emotional well-being. So let me tell you a little bit about our center and what we hope to accomplish. The center has a wide reach. It's available to all Mount Sinai Health System employees. In fact, there are approximately 45,000 employees. And we're working with hospital leadership, management teams, and key stakeholders to spread the word and get the word out about the center and what we're offering. And in fact, we've partnered with Dr. Zahi Fayyad to develop an in-house mental health screening app, which I'll show you some images of and screenshots of in a few moments. And this incorporated user feedback on all phases of development. It's actually already in initial rollout with a key group of stakeholders. Okay. Community involvement and community engagement is a also major goal and aim of the center. Working with Dr. Carol Horowitz and her team, we're using a well-validated community engagement model called an accelerator to develop the center. This involves engaging key stakeholders through structured focus groups, eliciting feedback, and building that feedback into the services that we offer. And in fact, we've engaged already multidisciplinary stakeholders from many of our hospital sites. Okay, this is our app. This is the icon for the app, the tree icon in the corner, which represents resilience. And the app is meant to be a resource for employees for self-screening. So there are standardized self-report symptom measures, including the PHQ-8. They can get automatic feedback regarding their scores and how they're functioning. And they can link to resources that they can utilize on their own, in their own time, or resources within the Mount Sinai Health System, including our center. There's contact information for our center, ways to email and call our center. So this is right now for iOS and is in our initial rollout phase. We developed this in about a month from concept to beta test. Okay, and actually now I'm going to hand this off to Dr. Katz.
Dr. Katz, we can't hear you.
Hello, everybody. Sorry about that. Hopefully you could read my slide, but let me tell you what I just said. Nice to see you all. And so I'm going to pick up where my colleagues left off and talk a little bit more in more detail about our offerings. So the resilience workshops that John alluded to involve what we intend to be resilience promoting workshops. And I say intend because some of this is innovation. We have taken Drs. Charney's and Southwick's research and writing on resiliency factors and developed and taken their superb book where they put together all of this in an evidence-based way and taken each of the different resilience factors, and we've made them into individualized workshops on each one. And so there are 10 factors, although there are 11 workshops, the 11th being an overall introduction to resilience, of kind of an elaboration of what Jonathan talked about a little bit about weathering adversity, but much more expanded. We're hoping, we are trying to offer continuing education credits to health providers for these workshops, although I have to emphasize that these workshops and our services are intended for all Mount Sinai employees, which by various counts is like 40,000 plus people. And what we are doing with these workshops is, and we want them to be co-led by peer leaders. And so we have been recruiting already from different populations within the Mount Sinai employee populations, different groups. We've already been working with physicians assistants, chaplains, nurses, and we are going to be looking for other peer groups, many others, given the diversity of workers that we have at Mount Sinai. And each group will be co-led by one of these peer leaders and one of the social workers who we have on board to help staff our center. And this is just a kind of a more detailed elaboration on what the workshop content areas are. The 10 of them are in addition to the 11th one on just overarching content, topic of resilience. And so we're going to go through each one of these, and we hope that people will attend as they see fit, all these workshops, but we're also going to leave it open to people to choose the workshops that resonate more with them and see how that goes. And you can see it's quite a range, the resiliency factors, from, as Jonathan alluded to, embracing optimism and spirituality to resilient role models, all the way down to physical fitness. So it's quite a range of things. And we hope that this also speaks to people's different interests and inclinations, and strengths and even weaknesses, right? We want to help people identify their resiliency promoting strengths and build on them and nurture them. So on top of that, so that's the resiliency workshops. Then we have our mental health screening and resilience coaching. So all employees are available for confidential mental health screening conducted by our staff. This service just started 2 days ago on Monday, and we have 12 social workers on board, standing by to offer these, which at the moment are all going to be offered, like most everything else we do these days, remotely. These screenings will be looking for the very same types of disorders that Jordan alluded to in her research. In addition to that, there will be opportunities for providing some resilience and wellness coaching as follow-ups to the workshops that we have. And if and when, and we assume when, we find mental health conditions in the people that we screen, that our social workers screen, we'll be working, of course, closely with our very own Department of Psychiatry for high quality referrals for the individual seeking treatment. And we will also use a range of support services, some of which I think you might have seen on those little screenshots that Jonathan showed from our app. We'll be referring people to Mount Sinai Calm, Mount Sinai Fit, working with our spiritual care services, and of course with our Office of Wellbeing and Resilience. So this is a little bit of a flow chart. So there we are, the Center for Stress, Resilience, and Personal Growth on the left. And you could see here, if you could see my cursor, that's a little tree logo for our app. Employees can get to us through lots of different ways, through the app, through calling us, through emailing us. And then we will set them up with a mental health screening. And if they screen in, as we say, for a condition and are open to treatment, we will then refer to our existing mental health treatment services through a centralized referral line. That referral, importantly, will be facilitated by the screening information that our social workers collected as part of the mental health screening. So our fellow workers won't have to, hopefully will not feel like they have to start over with their treating clinician, but we'll have all this information following them. And so it'll be smooth because it's within our own system. For those who, of course, decline treatment, we will have all the other offerings that we mentioned, including Mount Sinai Calm and the chaplaincy, and continuing to, or hopefully beginning to, or continuing to attend our resilience workshops. At the same time, our center really is in two halves. We have the clinical side, which we've been talking about, and then there's a research side headed up by Dr. Federer, Dr. Adriana Federer, who may well be on this Zoom call. And she will be directing clinical research activities in the center. Many of these are about to be operationalized. Some are in the works. It includes looking at comparing self-guided interventions with sort of some of the other treatments that we're offering. And a large-scale grant has already been submitted to support that very large-scale study. And then there'll be some biological-oriented studies on the relationship between stress and physical well-being, including wearables and something called the Warrior Watch that have been developed by our colleagues here, Zahid Fayed, that Jonathan referred to earlier. So there'll be a whole research component to our program, although we want to emphasize that our colleagues, our fellow coworkers, can get all the care that we're offering without participating in any research whatsoever. Our foremost concern is getting our colleagues the help that they need. And then to do all this, Deb alluded to this in her introduction. It is, as it said, it takes a village. In this case, it takes a lot of villages because this is an enormous effort. It is somewhat unparalleled, I would be inclined to say. And so we've been working with a number of the partners that we also want to acknowledge and thank, including Dr. Rip and the Office of Wellbeing and Resilience, and our very own Dr. Lim here in psychiatry, and Jane Sood in HR, and Diane Adams in talent learning and development, or we already referred to Dr. Fayad, and Dr. Horowitz with the accelerated development, which will help us get community-based participation in what we have to offer to make sure that we are not just sort of proposing something from our ivory tower, but offering something that makes sense to everybody out there on the ground. And that concludes our talk. And so I will stop sharing if I can figure out how, and turn it back over, I guess, to Dr. Khan.
All right, Greg.
Yes.
Yeah, thank you all very, very much, for all four of you, for these great presentations and giving a nice overview of what's going to happen and what the background forms for this interventional program, because clearly what we've seen from the data that were presented, this is really a great need. And it's only going to get bigger as we proceed in time. So we have some time for questions. You could either raise your hand. Yeah, Hillel Swiller raise the hand, and then we'll let you talk. And you can also use the chat box. So Hillel, go ahead.
First of all, this is a wonderful program. It absolutely sounds fabulous, much needed, and put together in a very intelligent way. But given the nature of the overall environment, I'm just wondering, how is this going to be funded?
Well, it is already funded. The dean gave us some money, and there was this, for the frontline workers, this money raising event, and it raised $1 million outside funding. It's a service center, and we are going to rely on philanthropy. There's no question about it. So far, we're doing okay, and that's where we stand right now.
Will there be any federal government support?
Well, that'd be a great idea. Hello. I've actually been in conversation with some folks in Congress about this. I think there's an issue much larger than who we are, but my understanding is that there is a movement afoot to liken this to 9/11. But maybe Craig, you may know more than I do about this.
Yeah, it's actually been a little surprising because Hillel, you may remember from 9/11 Project Liberty, and Oklahoma City, there was Project Heartland and Hurricane Sandy. I'm actually blanking on what the name was, but all these are from the FEMA crisis counseling program that gets rolled out and then administered by SAMHSA, the Substance Abuse Mental Health Service Administration. We relied heavily on those funds after 9/11 for our treatment services. There's been not a whisper about that. I don't know what's happened, but that's a federal law. I guess it doesn't mandate that funding be applied. I don't know if that's a product of the fact that the pandemic is ongoing, a product of the fact that the crisis counseling program really is based on the idea of person-to-person contact, and we're all so remote right now, or if it's a product of the political atmosphere. I don't know, but I would hope and expect that that's going to still be coming down the pipe, but I've been saying that for like 2-3 months now.
Thank you very much.
I think there's also from Patricia something on the chat box that maybe you want to pick it up, and then you can decide who's going to address it. Do you see it, or otherwise I'll read it?
Yeah, no, I do see it.
Okay, great.
I think Jonathan, I think you should field this one.
Sure. So we're working very closely with the Department of Psychiatry on.
It's very difficult to hear you, Jonathan.
Okay. Can you hear me now?
Yeah, we can hear you, but it's not very loud.
Okay. Unplug my headphones. Is that better?
Much better.
Okay, just no headphones. So we're working with the Department of Psychiatry very closely on getting our employees into treatment, and we will support the providers in behavioral health and the FPA in providing cutting-edge evidence-based treatment, medication management based on the current guidelines, and interventions such as IPT, CPT, and so on.
Okay. Great, thank you. Any other questions or comments? So I have a question, maybe to Deb, whoever. I mean, I think you've opened the gates on June 15th, is that right? Just a few days ago?
Yes.
So how is it going? Can we still handle the demand, or how is it going?
So we chose a soft opening, and right now we're not getting a lot of activity for the phone line, but I think that's partly because we're kind of strategically deciding how to reach out. For example, Mount Sinai downtown is very different. It has a particular kind of culture from leadership and the whole nature of the transformation, where they're very connected with one another. So leadership reached out to me just the other day, and they want a real rollout of Mount Sinai downtown. So those leaders are going to get the word out there. Because there are 940 plus physician assistants, and they were, as Jordan mentioned, those folks were hit very hard, and I gave you some of the reasons. So the leader of that group, Heather Isola, has been working with us. And I do believe that group is going to get they're going to learn about the center quickly and use us. So we're not picking who we want to go to, but there are people who've been coming to us already, and we're kind of rolling it out in lock, stock fashion, because we know we're going to make mistakes. You know, we know that it's going to be worse in July. The next couple, this was built really so fast, I can't begin to tell you. So, and with the accelerator, that's going to help get the word out too. And we'll monitor activity. You know, Jonathan's built these remarkable REDCap databases where completely confidential, you know, but we're going to be tracking everything from calls to the center, why they're calling this center, what our screens are done, where they referred, did they follow up with a referral, and attendance of the workshop. Long-winded answer.
Yeah, great.
A major, I mean, as you know, a big difference between this and our World Trade Center program is our World Trade Center mental health program was integrated within an occupational health program that was already established before 9/11, and then kind of converted to a 9/11 program, or had a 9/11 arm. So at that point, we were able just to kind of plug right into that. In this case, we are plugging into air, in a sense. You know, we're completely starting from complete scratch, and so I think that's the reason we're being kind of ginger in our rollout, because we want to be sure we have the resources in place to address what we think is going to be a large demand based on Jordan's research.
Yeah, no, absolutely. But you know, you want to be able to handle it if it hits you. Absolutely. All right. Any other questions or comments? All right. If not, thank you very, very much for this presentation. I think it's a great program. I think, you know, you guys have done an enormously difficult job getting it up and running in about 4 weeks, I think. So all the best of luck. And,
Thank you.
We'll stay tuned. All right.
Thanks.
Thank you very much. Bye-bye.
Thanks, Renee. Bye, everybody.
Thank you.
Bye-bye.